Subhash Dadeya will speak on diagnosis and management of MED.
Very good morning, good afternoon, and good evening to everybody. Thank you, AIUS, and thank you, Asia Pacific Society, for inviting me to speak. So basically, my screen is visible?
Yes.
So basically, it is defined as inability to elevate the paretic eye from any position of gaze, provided ductions are normal in all other positions of gaze. It may be paresis of superior rectus and inferior oblique with ptosis, or superior rectus palsy of long standing. Earlier, it was known as DEP, which was coined by Dunlop. It may be congenital or acquired. It may be paretic or restrictive. It may be supranuclear, but MED is more accurate term, as paralysis of both muscles independently and supranuclear lesions can lead to impaired unilateral upgaze pulse. There could be congenital causes, supranuclear defects, superior rectus paresis, inferior rectus restriction, neonatal hypoxia. In the acquired, there may be CVS disease, midbrain tumors, then sarcoidosis, infections, and in our setting, cysticercosis is an important cause of acquired MED. This is ultrasonic picture of one of the patients of the cysticercosis who has MED. Then it is classified into type 1, type 2, and type 3. Type 1, where prominent feature is restriction of the inferior rectus. In type 2, prominently there is weakness of elevators, and in type 3, both the combined mechanism. So what are the clinical features? Limitation of elevation above midline, both in abduction and adduction, hypotropia of the involved eye, presence of ptosis and pseudotosis, chin elevation. In most of the cases, MED is unilateral. Marcus gun jaw winking phenomena is present in 25% of the patients. This is one of the photographs of the patient of MED. So for diagnosis, it is very important to ask history of onset, and if sequence of events are not clear, then presence of amyloidea suggests congenital etiology. You must look for previous photographs. For acquired causes, you must see the history of neurological symptoms, past medical records, and general systemic symptoms. In type 1 DEP, there is positive FDT, normal FGT, normal skates, and there is deeper lower lid folds, and Bell's phenomena is negative. In type 2, FDT is negative, reduced stacked velocity, there is reduced force generation, and intact bells and skates, they are absent above midline, which suggests a supranuclear lesion. Then in acquired DEP, it is acute acquired diplopia in upgaze. Ptosis is not a prominent feature. You will see the pupillary anomalies, convergence weakness, and neurological symptoms. It is very important to differentiate acquired from the congenital. Differential diagnosis could be Brown syndrome, vertical Duane's, congenital fibrosis of inferior rectus, congenital absence of superior rectus, inferior oblique, abnormal insertions of the muscle, and partial third node palsy. For acquired, there may be thyroid orbitopathy, myasthenia gravis, orbital fractures, third node palsy, previous cataract surgery, cerebral tumors. This is one of the patients who was having myasthenia gravis and presented as acquired MED. Then what are the indications for surgery? If there is significant abnormal head posture in primary position, that is indication for surgery. Significant vertical deviations in primary position, contracted binocular fields, diplopia in primary gaze. In most of the patients, we have to observe the patient, because with limited head posture, the patient can maintain orthophoria, and treatment for double elevator palsy or MED is surgical and only surgical. The goals of surgery are to achieve cosmetically acceptable deviation in primary position, to increase field of binocular single vision, and it is very important to tell that surgery will not cure the MAD. More than one surgery is required, and ptosis surgery should always be done after strabismus surgery, because most of these patients, they come with the complaint of the ptosis, and they are more concerned about the ptosis. So ptosis surgery should always be done after strabismus surgery. Optimal surgical treatment for MAD remains controversial, and treatment should be according to the type of MAD. Type 1, which is usually 75% of the in 75% of the patients in our setting, and recession of the involved inferior rectus is the treatment of choice for type 1. And type 2 MAD NEPS procedure is a well-established and commonly practiced procedure, but drawback of NEPS procedure is patient loses some abduction and adduction, and effectivity decreases if deviation is more than 25 presumed diopter. These are the steps of the NEPS procedure. Esophageectomy with vertical muscle recession are effective according to the Chinese study. Sneer et al. Recommends NEPS procedure with posterior fixation sutures, and DP with horizontal deviation is a separate entity in which modified NEPS procedure is quite effective in our hands. This is the preoperative photograph of the patient. This is the postoperative photograph. Then another patient with preoperative MAD. This is the postoperative photograph immediately after the surgery. This is another patient with the MAD. You are seeing the post-operative photographs, and final picture is after the ptosis surgery, good correction. When to intervene for ptosis? You should wait at least minimum of 6 months after subsequent surgery, because magnitude of vertical correction increases with time following NEPS procedure. Thank you very much for your kind attention.
Thank you very much for